Hi and welcome to Physiotutors podcast episode 68 with Edel Fanning from Ireland. Edel is the lead upper limb physiotherapist at the Sports Surgery Clinic in Dublin. As part of her PhD, which she finished in 2023, she has published several papers about return to play after glenohumeral stabilization. Today, we will be talking to her about the athletic shoulder. Hi Edel, welcome to the pod and great to have you as a guest.
Hi Kai, thank you so much for having me on your Physiotutor podcast. It is great to be here today. Thank you.
Sure, looking forward to the episode and to start, when we talk about the sporting shoulder, which pathologies do we have to consider in particular?
Yeah, I think that's a really good question because I think it often depends on the sports. Obviously, some sports are a little bit more prone to shoulder pathology in the beginning, and different sports are a little bit more prone to different pathologies. So, for example, in Ireland, we see a lot of contact athletes, or collision sports as such. So, a lot of our sports inherently are things like GAA football, Gaelic football, hurling, rugby are some of the most popular sports, and a lot of kids play that from a very early age. And unfortunately, things like shoulder dislocations are very common in some of these sports. Say, for example, particularly in youth rugby, adolescent rugby, the most injured joint is the shoulder joint out. There's some really nice studies looking at the kind of epidemiology of injuries. And so that's a big pandemic of at the moment. Traumatic shoulder dislocations in rugby in particular, but also a lot of the other contact sports. So we see a lot of shoulder dislocations. The hospital I work in do over 400 staves a year, primarily in male contact athletes. So a huge amount of those. And they are obviously, some of those can be coming at a lot of trauma, a lot of bony injury, and can be quite devastating on a career, particularly in that young athlete. So that's one cohort. In Ireland may be a little bit unique in that, but also in the States, NFL would have a high risk. Ice hockey, wrestling, jiu-jitsu, some of those sports are high risk for shoulder instability and shoulder dislocation. And I think, in Europe, some of the handball as well, you might come across some of the traumatic dislocations as such. And then, of course, you have your other pathologies like your rotator cuff issues, things like rotator cuff tendinopathies or traumatic rotator cuff tears. And they're certainly more common in, say, some of your throwing and your overuse or excessive tissue load or change in load type sports. So things like swimming. So we know swimming in particular, your most predominantly injured joint is going to be the shoulder just because of the nature of the sport. Some studies show anything up to 75% of professional swimmers will experience shoulder pain at some point. So you've obviously got that cohort, and the same with your tennis, for example, or your baseball, things like rotator cuff tendinopathy. And when I talk about rotator cuff tendinopathy, we've very much moved to that kind of generic term, which encompasses things like lots of different names like bursitis or partial rotator cuff tear, like a lot of those morphological changes you might see on the scan. And then occasionally you can obviously suffer a traumatic tear, occasionally with a shoulder dislocation, or through gymnastics sometimes you'll come across some of those traumatic cuff tears, through an injury or a specific injury as such. And then your other kind of cohort to think about is that anterior shoulder pain. So you might get things like long-headed biceps pathology, and that's kind of a bit of an entity on its own, which we'll probably discuss in time. Or like a slap lesion, so where the superior labrum pulls off where the long-headed biceps tractions on the superior labrum. Now, a lot of those we know from scans and things can often be morphological, but they're the ones where they might have a specific trauma. So they fell on an outstretched hand and had a compression force of the humeral head up, which may have tractioned the long-headed biceps. And And again, there's a huge debate on whether to operate or not, and which ones may do well with surgery, and lots of things to consider on those type of pathologies. And then your other type, of course, is your acromioclavicular joint issues. Again, this is a big problem in traumatic in contact sport. In adult rugby, the most in terms of the shoulder, the most common type of injury is often an acromioclavicular joint dislocation or subluxation. So some of those traumatic injuries to the acromioclavicular joint. So that's another one to bear in mind. You can get degenerative changes through there, and then you can get overload changes to the bone as well, and to the end of the clavicle, osteolysis and kind of changes like that, depending on the different sports and stuff. And then the other last thing to think about, neck and nerves, any kind of referral from that. Any types of traction and nerve injuries are the other things to consider. So yeah, a little bit of a whirlwind visit, but any pathology you can get in anybody, you can get it in a sporting shoulder. It's not necessarily any different to a recreational or anybody else who isn't playing sports. You can of course get all the kind of same pathologies. It's just often, particularly in the contact sports, with the amount of trauma they can often come with quite big structural changes and bone defects and things like that. So sometimes they're managed slightly differently depending on what kind of structural damage they've done.
Yeah. So to summarize, in contact sports, it's mainly the dislocations, maybe also including the AC joint dislocations, and in the more overused population or in the overhead sports, which are non-contact, mainly it would rather be rotator cuff tears plus minus biceps, or not only tears, but tendinopathy and also biceps tendinopathy. Is that correct?
Yeah, absolutely. Yeah, so you certainly kind of think of more rotator cuff pathology, and in some of those overhead sports, things like, slap lesions and stuff. But again, a lot of that can be morphological. And then when it comes to long-headed biceps, I think true biceps tendinopathy is actually very rare unless you have a real concentric or eccentric contraction through the biceps. A lot of that is because it's interarticular but extrasynovial. It's got a sheath around it. So often long-headed biceps is almost secondary to some rotator cuff pathology or glenohumeral joint pathology, and you get some sort of referral. You'd rarely get a long-headed biceps tendinopathy on its own unless you've had a real concentric, eccentric contraction. But yes, certainly you're more common to your rotator cuff related pathologies. And then you get acquired laxity in some of the sports. So you can get some of this, atraumatic instability essentially in the shoulder. If you've got acquired laxity, can they control the whole range? So that's the other kind of cohort to probably think about in some of those throwing sports or the, the swimmers and things like that. Have they got full control to manage that acquired laxity? And they can sometimes end up a little bit uncomfortable and can end up with some muscle patterning issues and things like that as well. But yeah, I think they're probably going to be some of the main things that you'll see in those kind of cohort of athletes.
All right. Yeah, I think for this podcast, we covered, or we had other podcasts where we covered those pathologies in particular. I think for our podcast, my goal is to focus more on return to sport and on performance. One of the questions that I basically discussed with all of the shoulder experts is, what is the role of the scapula? And I think there's been a lot of discussion in the past about whether the scapula or scapular dyskinesis is a risk factor for the development of shoulder pain. But also, what is the role, and that's my question to you, what is the role of the scapula in shoulder stabilization, and also how important is it for performance?
Yeah, no, and I think that's a really good question, and you're right. There's always some debate around the scapula, isn't there? And certainly some papers, when we look at if we screen scapular dyskinesias, is it predictive of pain throughout season? But the big difficulty there is there's no reliable way to screen scapular dyskinesia. There's quite variability in between whether someone thinks there is scapular dyskinesia there or not. And then we know it's present in asymptomatic shoulders. So in terms of, and I think probably, I remember chatting to a lot of the kind of colleagues and, fellow kind of the shoulder physios and people like Anne Cools and stuff with this. And we, I think the general consensus a lot of us feel in the present, if there's obvious scapular dyskinesis in the presence of pain, we'll probably explore it a bit. But if we see it in an asymptomatic shoulder or as a screening tool, it's probably not so useful. And then, of course, you can use things like improvement tests to see if it's something you may target. Now, for me, how I kind of view the scapula is it's essentially the socket of the ball and socket. So, of course, it's a crucial component of the shoulder. And it's the attachment for all of the rotator cuff muscles and all those other kind of muscles around there. So it's important if the scapula is obviously out of sync, or if the rotator cuff isn't functioning very well, you'll often find the scapula has to compensate and vice versa. So they work very much together to allow that muscle balance around the shoulder. And I don't think we necessarily have to think of it as a rotator cuff or a scapular issue. If you target one, you're going to target the other. Yeah. As I said, the rotator cuff muscles attach onto the scapula. So if you are training the rotator cuff and doing some rotational type exercises, actually the scapula has to stay stable to allow you to do that. So you're naturally going to be targeting some of those movements. And the same if you're trying to chase things like upward rotation in the scapula. Lo and behold, through flexion, for example. Well, we know the posterior cuff is very dominant through flexion, so you're going to be training some of the scapular muscles and vice versa. So I don't think you can kind of separate one or the other. They're both very much linked, and because it's the socket essentially, of course, it's a crucial part. And then obviously not forgetting the role the whole body plays in that, and the role of how the kinetic chain can affect the upper trap and lower trap, ratio. So there's lots of things to think about. But certainly, in the presence of pain, if you see scapular dyskinesis there, it's probably something you want to bear in mind. But actually, whatever way you address, or you might find some rotator cuff deficit there, you'll generally find that the scapula is going to start, you're going to be addressing those muscles as well. And you can probably, how I would approach that sometimes, say, for example, if I thought, through internal and external rotation, the scapula was hitching up quite a lot, and that can be for a few different reasons. They may struggle with scapular stability, or they may struggle to let go of eccentrically lower that, as you internally rotate, struggle to allow the posterior cuff to let go. So you might put them in positions where you can challenge the scapular stability a bit more while you chase the rotator cuff. So, for example, rather than lying them on the back where the scapula is quite stable, you might put them in a prone position where the scapula has to work a bit harder while they train the rotator cuff. So you can probably be a little bit cleverer sometimes in how you approach those. But as I said, no matter what, if you're chasing one, you're going to probably chase the other. So I don't know if I've gone off track there a little bit on you, Kai, but...
No, I think you added to an opinion that we formed quite a while ago in the last podcast with Philip Strauff, where we talked about scapular dyskinesis. He also mentioned that scapular dyskinesis might be a way of the scapular muscles trying to help the rotator cuff. So he actually portrayed it the other way around compared to what we thought in the past. So that was kind of an interesting discussion that I had with Philip. But I think all of the experts are basically more or less of one opinion nowadays when it comes to the scapula.
Yeah, absolutely. And I think it helps simplify things a little bit. I've been treating shoulders for a long time, and back, say, 15 years ago, you used to do lots of stuff where you look in the mirror and look at keeping, is the scapula stable as you go and move. Yeah. And then you tend to be often just, you can be really just quite logical. Going to 4-point kneeling, it's a lower load for the shoulder. And you can often get the rhythm quite nicely in a closed chain 4-point kneeling position. Go to a wall slide. Suddenly the scapula looks great when the weight of the arm is gone. Train it that way. Then take the wall away and you can go into a Y-type exercise and then into an overhead press or a jammer. So you can just be quite structural in how you load that without having to probably overcompensate it or overthink it as such. I certainly find that much more effective I think some people can often get very fixated. Even the patient themselves can get quite fixated on the feeling of the shoulder blade. Is it in place? Is it out of place? So I'll often try and use external cues now rather than internal body cues, so they're not quite fixated. And a lot of them don't know what's right or what's wrong, so I'll often keep the exercise quite functional, and external cues like reach for the ceiling, punch up towards the ceiling, to get that upward rotation rather than, bring the shoulder blade up. I often find that much more effective as a coaching tool.
Yeah, agree. I think that's much easier for a patient to perform as well. Hey, and talking about the musculature, I mean, we always mention the kinetic chain. Apart from the rotator cuff and the scapular muscles, which parts or which muscles of the kinetic chain should also be considered in rehab?
Yeah, and again, that's another really good question, and often quite a controversial question between lots of therapists and things like that. For me, how I view the kinetic chain, I view it as a way in to facilitate local recruitment, to optimize local recruitment, Ellie Richardson over in the UK put out a lovely systematic review looking at the role of the kinetic chain in shoulder exercises, and they found stuff like, say, when you do a step forward, while you're doing some Y-based exercise or some exercises like that, often including the kinetic chain through things like a stepping technique will help improve that upper and lower trap ratio. So you might optimize the timing of the shoulder blade muscles a little bit. And some of that's just trial and error. I'll do with a patient. If I add in a step, does it look better? Some of the studies show that stepping is better than a squat, for example. But again, it's a bit of trial and error. But I'm constantly thinking normal motor control. It's that kind of what helps, what works for the patient, what connects it. You're constantly trying to fire up the motor cortex. So again, I'll try. And for some patients, that works beautifully. And other patients, they really struggle to motor plan when I try and add in a kinetic chain component to, say, a local shoulder exercise. And again, other studies have shown that if you're trying to, you can't really isolate the rotator cuff, but if you're trying to work on some of those rotational muscles, actually adding the kinetic chain in probably isn't the most effective way of doing that. So perhaps sometimes if I want to work locally on the rotator cuff stuff, I may try and focus on that. But if then I might play around with some other exercises, adding a step in, trying to fire up the motor cortex, help local recruitment. So that's one way of viewing the kinetic chain. And I don't think there's one specific muscle group that's important. Again, sports are important, for playing tennis. 50 to 55% of the power comes from the rest of the body. So if you have a deficit lower down, some of the biomechanical studies have shown that affects your velocity and some of your throwing sports. So you're going to have to think about keeping the rest of the body really good. For me, with these type of athletes, for me with these type of athletes, I'll often screen them. So I'm fortunate to have access to things like force plates. So we do like a counter movement jump, some of the single leg jump stuff, and just seeing if there's a huge deficit from one side to the other. And then we'll often target that, and sometimes we'll target that just with their gym program, some of the lower limb stuff. And then another way of targeting that is you can incorporate it in with your shoulder rehab. So there's a couple of ways, but absolutely, no matter what athlete, you're going to be thinking about the rest of the body. If you're rehabbing them post shoulder injury, that's a good time to optimize everything. If they've had an old hamstring thing, or it's just a beautiful time because they're going to be in rehab anyway for a period of time. So it's always a really nice time to optimize.
Okay. Do you think it's fair to say that an overused shoulder injury might be the result of deficiency in a more proximal part of the chain? Say, if I don't have, for tennis serve, for example, if I don't have good core muscle strength for my rotation in the serve, then maybe the load on the shoulder will be higher, and that's basically the part of the chain that breaks, for example.
Yeah, absolutely. And I've even come across that, in my, I think we've all come across that there's times where I'm like, particularly, we don't obviously have loads of baseball players. We certainly have some tennis players and some youths on the European tour, so they sometimes you'll sometimes come across some of those, but it's the cases where you're like, the shoulder's brilliant, I've tested it, it's really good, and then they go back and they continue to break down. And I've got a couple of cases in my head like that where you're like, and they may break down at the shoulder, they may break down at the elbow, and they are the ones you absolutely want to be screening for. Whatever your lower limb kind of screens you have in there, as I said, generally with that type of athlete, first session will screen the whole body. And that's just some simple functional tests on the force plates. Are they able to generate force more than one side or the other? Okay, let's break that down a little bit. If you haven't got access to that, you've got all your other tests, and like your single leg squat. What's that like? Your squat generally, and there's lots of different ways to look at screening the body. Excuse me. But absolutely 100%. And no matter how robust the shoulder is, if you've got a deficit, a persistent deficit lower down, you can't wind up the same. You can't transfer force the same. You have to be able to explore that. And I would absolutely say do that on your first session, because there is nothing worse having to unpick and unravel all of that further down the line. Player gets quite frustrated. Yeah, expectations start changing, and you want to really, as I said, just bulletproof them as much. And then the other component there is there's lots of other in terms of technical aspects, isn't there, that might predispose. So sometimes it's quite a minefield of things to consider.
Yeah, I think we already started talking about injury prevention or injury reduction. What can we do for our athletes, or what can athletes do to reduce the risk of shoulder injury? I mean, it's a pretty broad question probably, but is there any data that we have from systematic reviews or from studies, or is there anything that works in your opinion?
Yeah, no, that's another really good question. I think when it comes to, say, the type of athlete I see a lot, which is traumatic. So these are the rugby players, and unfortunately it's just, sometimes they can go in on the wrong foot as they're going in for a tackle, or they get caught out with a long arm, or when they go down for a try position, the arm gets caught in an outstretched position. I'm not really sure how preventable some of those labral changes are, some of those dislocations are. We get a lot of athletes with panlabral tears, so the whole entire labrums come off. Not through one mechanism, but just through multiple contacts and collisions. We know, a guy called Montgomery, who's actually based in Ireland, they did some video analysis on some of the rucks and things, and some positions are more likely to dislocate the shoulder. Tackling's a high risk. Your ruck is a high risk. Your poach position is a high risk. So I'm not sure how preventable some of that is. All you're trying to constantly do is get them as robust as you can. Yeah. But certainly in your cohort, which may be more common probably where you guys are, the handball players, for example, Martin Asker has done a beautiful study. A lot of his research has looked at, particularly they've quite a pandemic, I think, in the youth handball players. So they followed a cohort of the youth handball players, and particularly female youth handball players tend to be a high risk. And then they kind of identified this cohort, and then they put in place, I think they did it for the knee and the shoulder, this study, and they put in place a program to optimize shoulder health, essentially, and then looked at it compared to a control group, and did it have an effect? And I think the absolute risk reduced by about 11% in the female, or in the cohort of the athletes that were training their shoulders, that were doing some stuff to maintain health. And I think between the control group and the other group, there was about over a 50% difference in injury rates. With as I said, the absolute risk was about 11%. So that's actually quite strong data, isn't it? And that was a very well controlled study. And, so I think probably in that cohort, it looks like there may be. Then you'll have other studies that show, it's actually quite difficult to predict shoulder pain and how useful is it. But I certainly think it's probably something worth exploring in some of those overuse injuries as such. And again, probably not just the shoulder, making sure the whole body is optimal. when it comes to contact and collision sports, yeah, I think there'll always be an element there just because of the trauma of the sports, the size of the players, no matter what you do.
Okay, and are there any specific warm-up routines that you could recommend? If I look at football, for example, there's quite a lot of studies on the FIFA 11, or nowadays I think it's the FIFA 11 Plus, that has shown quite a reduction in injuries in soccer players. Is there something similar, maybe in specific sports or in shoulder injuries in general?
Yeah, they have a similar one for the shoulder. So they have a similar one to the shoulder as they do for the knee. And in terms of that, like, there's no magic exercise. Like for me, say for example, the swimmers and things like that, you do things that are easy to do, that they can, they don't need loads of equipment while they're out on the side of the pool or on the side of the pitch. So like some of my go-to exercises, I always love a Y exercise where you put the yellow band, or, a band around the outside of the hands, and you're trying to switch on the posterior cuff, just because it's so easy to do. You can do obviously lots of rotational based exercises, elbow and knee where the arm's supported and doing it against some resistance or some weight, and they're getting a nice fatigue. For the contact athletes, often things like bear crawls, where they're just getting some proprioceptive feedback. So that's a lot of stuff they do on the side of the pitch. So things like the bear crawls, the grappling, and that kind of thing where you don't need equipment. So say they're waiting to go on. So those kind of things are often quite functional and just easy to do because you don't need equipment. So again, I think it's sports specific. And then obviously if you're a tennis player, your baseball players, those kind of things, you want to keep the posterior cuff good, don't you? Because obviously the anterior musculature is generally more dominant. So you're trying to do some of your posterior cuff stuff. You'll probably bias that a little bit more. So some of your external rotation exercises or your flexion-based exercises are obviously a good way to engage the posterior cuff. So you'll probably bias them a little bit more towards that. And I think you're talking, you don't have to be at it all day. Kind of 10 minutes of kind of some functional stuff there, I think. And generally the shoulder appreciates that, or it feels nicer, to then get into whatever sport you're getting into.
Yeah. Okay. Thank you for your answer. If we look at pre-season for athletes, then a lot of clubs or professional athletes perform screening tests. Are there any screening tests that you consider useful? I know there's also a lot of debate about it. For example, if I look at strength ratios between internal and external shoulder rotation, some authors describe like ideal ratios or ratios that basically make the athlete more prone to shoulder injury. Is there anything that you deem useful?
Yeah, and again, that's quite a debatable question because, as you probably all well know, like some studies will support the use. Oh, actually, if there's a deficit in if there's an imbalance in the ratios, there's a deficit of interlimb asymmetry there, or scapular dyskinesia, or a glenohumeral joint internal rotation deficit, that all may be predictive, And then other studies show the complete opposite. And I think that's really a few things to consider there. Absolutely sports dependent. I'm not sure how useful that is in, say, some of your contact sports. But also in some of your overhead athletes, it may be more useful as we know, as I said, Martin Asker's study and some of the other studies have shown that as well. And I think when it comes to that, it's what have you got access to, A lot of those tend to be field-based. So again, it depends what you have access to. It is hugely time consuming to screen your athletes as well. So you're trying to weigh up the benefit of the time being put into it to what you're going to get out of that as well. So there's so many factors to consider. What resources you have, is it actually going to benefit them? So I certainly think perhaps in some of those overhead sports, it may be worth taking some baselines. And again, it purely depends what you have access to. How reliable are you as testers testing those, and how meaningful are the tests that you are looking at? So you've got those kind of factors to consider. Like in terms of the shoulder, like whether it is or not the gold standard, but what most is commonly looked at is that rotator cuff, your rotational strength. So things like interlimb asymmetry, what's it like compared to a normal cohort, and that ratio. So you got to know all of these within your athletes, because every cohort of athletes is different. There's difference between males and females. Swimmers are different to tennis players, very different to contact athletes. So you need to kind of know all that information for it to be useful to you. And then you got to be reliable testing. So if you're using a handheld dynamometer, for example, you have to be stronger than the person you're testing. So you've also got those. Otherwise, like you're going to end up with quite a measurement error. For example, when we were carrying out our research in the clinic, we tried to look at range of motion to include in with some of the other tests that we were looking at. We could not get ourselves reliable in testing range of motion, and these are probably amongst clinicians that only see shoulders and see a lot of shoulders. And then you look at it, and I was speaking to Anne Cools at the time, because they've done a study that shows you can reliably measure range of motion. And she was saying, actually, that was we used students, and it was quite a setup way. So they didn't have the clinical knowledge there. So they were probably just following a set rule, and they were able to be reliable with a phone, with a smartphone. We could not. We tried it for a year. I did so many pilot studies, could not get ourselves reliable. So we couldn't use it. And the measurement error was huge. You're talking 25 degrees, which is massive, in total range of motion. So, yeah, and I get asked this a lot, because often clubs, I chat to clubs quite a bit, and they're like, what kind of testing tools can we use? I'm like, what have you got access to? Are you reliable? And I'm often like, pick a few key tests. Is there? If you start, everybody's trying to test. You don't know if these are reliable or not and what you're getting, particularly when you're using things like handheld dynamometer and stuff. The force place isokinetic machine obviously is higher. Reliability is higher there, but yeah, pick a few key tests, as my advice would be on that, and pick tests that are meaningful. I find the functional tests, for example, quite difficult sometimes, because I'm like, okay, they're not testing well on a white balance test. What does that mean? What am I going to train from that? And again, the literature is just quite mixed, whether, it's useful in terms, there isn't enough literature out there in terms of, is it useful in, predicting anything and that kind of stuff. But as I said, pick something meaningful, pick a few key markers, and then go from there. And then where maybe is if they develop an injury, you've got a baseline to look back to, haven't you?
Yeah. Okay,
but it is a tricky one. Yeah.
We had a whole episode with Nicole van Dijk, who is specialized in hamstring rehab, but also injury prevention or injury screening.
Yes,
so I think if someone's interested in the limitations or the value of injury screening or injury reduction, that's a good episode to listen to.
Absolutely.
Moving on towards the exercise part of rehab, I had a look at your course outline, and one of the chapters you mentioned there was you mentioned exercise dilemmas. What do you mean by those, and could you give a couple of examples?
Yeah, so I think in the course I've got some kind of nice case examples around, say if we take a stabilization. So, for example, ladder J procedures are quite common here. So that's where they use the coracoid and they transfer it across the front of the shoulder, and so almost like a bony block. And they struggle with certain kind of things. And because of the approach, they often have a deficit in the anterior cuff. So what might be your go-to exercise is to try and optimize that, for example. Or your other types, like your soft tissue Bankart repair, or a remplissage, is where if you've got a big, what you call a Hill-Sachs lesion, they almost stuff the back of the cuff and the capsule into the Hill-Sachs lesion, and they really struggle with external rotation. So often at certain time frames, they've got deficits in these ranges. And what are your go-to exercises? And just often sharing some of those techniques from seeing a lot of them and having to test a lot of them. We generally use objective-based criteria to return to sport. So they need to be testing good before they go back. So what are your go-to exercises? Or if they're down on some of the performance tests, on explosive, jumps and things and like them, what are your go-to type exercises for those? So yeah, kind of breaks into that. I don't know if you'd like me to share some ideas around that, or
yeah, sure. Why not? Like a couple of concrete examples.
I think probably one of the big things is often external rotation in, say, post-shoulder stabilization, trying to optimize control and range there again. And the big thing for me in these is with the shoulders, not often true stiffness, you know, it's the shoulder's heavily reliant on muscle control, and if the muscles aren't doing the right job, it's not going to let go, it's not going to give you the range. So I approach a lot of these with trying to really optimize lots of support in the joint, lots of proprioceptive feedback to allow it to let go. So certainly things like when I'm working on external rotation, starting the flexion plane, for example, it's a really supportive position. They'll often let go in that flexion plane. So whether you have the elbow on the knee, the elbow on a gym ball, it's fully supported, so it doesn't have to stabilize the shoulder and rotate at the same time. You can just focus on getting it to learn how to rotate again. And your other big thing is giving it lots of support. So prone positions are beautiful positions for the shoulder, no matter what, whether it's rotator cuff related pain, instability, giving it lots of support or a physical block on the front of the shoulder. You'll be surprised how quick it begins to let go, again, based on time frames and what you are allowed, what ranges you're allowed to go into. But things like a prone position over a bench, for example. So you kind of got that anti-gravity position. You're lying prone over the bench, the shoulders fully supported, and allowing them to engage that external rotation. It's night and day. Lying them on the back, no support there. Blocked here, put them prone with a support, you'll suddenly see that open up. And that is also one of my go-to exercises for things like tennis players, because often where their deficit is in that real inner range external rotation. So one of the beautiful ways, there's no point training to here, they're often very strong here, is learning to access into these. So putting them in those prone positions is a really nice way before you're starting to band them. You know, it's quite hard to have a band on, keep the resistance on, let go on, and often they just can't fight against that resistance to get into those inner ranges. So think support, you can be really clever, think position, think support, think proprioceptive feedback, your use of gravity, and then your use of resistance, not just thinking resistance. And we know from lots of the EMG studies from Karen Ginnard in Australia, some beautiful work, actually by adding more resistance bands, and you're not getting more rotator cuff, essentially, you're getting more of all the muscles that externally rotate. Whereas playing around with positions is often more effective. And we know often there's more supraspinatus activity, not that you can ever isolate these, in 90 degrees of abduction compared to them by your side. So you can be really clever in how you access that. But your basics of things like support, proprioceptive input, and position, gravity, and I think that's what makes physio fun as well. You know, you get to you always get a way in, getting that safe entry level and then pushing on from there.
Yeah, I think that this is a good spoiler and appetizer for the upcoming course that we are designing. I mean, I don't see too many people post-operative or with shoulder instability. So for me, this is very interesting to see how I could build up an exercise program dependent as well on different procedures that have been done during surgery, for sure. And we talked about instability and surgery, and one of the instability pathologies are AC joint injuries. Are they different, or do we need to treat them differently? I feel like a lot of clinicians struggle what to do with AC joint injuries.
Yeah, and they can be the tricky ones because they can be sore. And it's very much a joint pathology, isn't it? So how I view the acromioclavicular joint, you know, your common types of pathologies are going to be things like your separations, your subluxations, dislocations type of thing. And then you can get obviously degenerative changes, and then you can get some overuse and bone load changes at the distal end of the clavicle. Then the other big thing is clavicle fractures. Again, through contact sports, we see clavicle fractures, and our jockeys, we have a lot of jockeys. So we see clavicle fractures. So they tend to be probably your most common things that I would associate with the acromioclavicular joint. And certainly what you find with these, say for example, someone's had a fall directly onto the shoulder and suddenly has a step there. So they have, they've changed the stability of the joint. Often the acromioclavicular joint on top is disrupted in the capsule, and then you've got your coracoid clavicular ligaments that go vertical, and then you lose the vertical stability and the horizontal stability. And that's a huge player in the role of the shoulder because it's the only thing connecting the clavicle to the scapula. And when it comes to optimizing that, there's a couple of ways of how I view this. The big players that I'm thinking about is obviously the scapula. Often the cuff is pretty good in these shoulders. They haven't done anything to the cuff. The cuff is generally okay. It's optimizing that scapula to take the load from that joint. So really trying to optimize things like your upward rotation, your protraction, retraction. But the other big player in there is your trapezius and your deltoid. So you've got your trapezius that attaches onto the posterior part of the clavicle, your deltoid that comes onto the anterior clavicle, and they blend into that fascia almost of the capsule of the acromioclavicular ligament. And they're really good in helping stability, particularly with your acromioclavicular joints, with your steps, your ones that have those kind of injuries. And I'll do lots of things to try and engage the delt and trapezius almost to give that compressive force to the joints. So things like bow and arrow, you know where you're here and you got the elbow in line and you're doing that kind of stuff. So you're working the deltoid and the trapezius quite nicely. So they work beautifully in that type of athlete. And stuff then that follows on from that, like protraction, retraction. So I'm always thinking deltoid, trapezius, kind of fascia in around there, optimizing the scapula as well to really optimize the mechanics of that joint. And then be careful with things like your press ups and stuff. They generally will tend to annoy it. So you'll often do some of your pull work before you're adding any of your push work back in. But I'm often thinking, try not to annoy this joint. When it gets sore, it is a pain. And what we find with a lot of our athletes, they get injected. So they'll try and inject the joint, which works quite well for a short period of time. Then they go back and play and it's still sore. They get injected again, then they go back and play. And it's very hard to get a period of time. You're almost, if you can, let it settle. If you can get a good 4 to 6 weeks on a post disruption of the ligaments, if you can get a good 4 to 6 weeks on it, really optimizing the scapular biomechanics, working on your deltoid trapezius, doing all of that kind of nice bow and arrow stuff, lots of protraction, retraction, optimizing the scapula. It'll often settle quite nicely and it pays off that they're not constantly coming in and out because they can be really, really tricky to manage. To then go back into example, kind of some of your contact sports. But this is also for your degenerative acromioclavicular joint, With those kind of ones, you're always thinking optimizing that scapula. And some of those may have some related pathology because often then once they've had a degenerative acromioclavicular joint, there's pain, everything starts moving a little bit differently. Often the cuff will be down, probably more so in those. So you'll then start to often tidy up the cuff, trying to really work on optimizing the scapula so the acromioclavicular joint isn't getting loaded. And then finally, the other thing you might see on the rare occasions is rather than a traumatic dislocation of the acromioclavicular joint, an atraumatic one, so kind of severe muscle patterning in a very lax shoulder can cause instability around there. I've certainly seen that on a couple of occasions with people who compete in archery and a few other things, and they can become quite tricky and then sometimes end up with an instability at the sternoclavicular joint, which can be extremely painful and tricky again. But yeah, you're certainly thinking more around that scapula than probably just rotator cuff at this kind of cohort. But again, as I always say, if you optimize one, you will influence the other. So
okay, yeah, great stuff. So it is a quite nuanced approach also for the AC joint. It's not just do your rotator cuff stuff and you'll be fine.
Yeah, no, I think you can be clever, and particularly in these these traumatic injuries, the cuff is okay in these. These don't test weak on the cuff. And even to you'd have to be clever in how you target the rotator cuff, because you're not going to prone these patients. If you prone them, the joint is like, even if you have the elbow supported here, the joint is here. I had one the other day, and at the elbow here, you know, he's got a cuff tendinopathy on one side, an ACJ injury on the other side, and he's a grade 4, so he's right up here in this position. Just lift it off, but actually lie him on the back, scapula is completely stable, work the rotator cuff. That's a beautiful position for an unstable acromioclavicular joint, lying on your back to activate the cuff. So yeah, you'll always think positional a little bit with these rather than, I certainly think particularly in the unstable ones, you have to be a little bit clever in how you position them to have that proximity of the joint to then allow them to activate some of these other muscles.
Okay, moving on towards return to sport decision making. I'd say for the question, pick a specific sport that you like or that you see often. But do you have specific tests that you guys usually perform to help that decision making?
Yeah, and again, this is very sports dependent for us, because we see the contact athletes and we see male contact athletes primarily because they tend to suffer much more dislocations than the female athletes. And so we have a number of tests we look at. We look at rotational strength. We chose that because that was the gold standard. We've got some literature out there already with something to compare to. We use an isokinetic machine because we have access to it. Now, rather than just looking, and this is probably one of the important points when it comes to an isokinetic machine, it'll actually, when you look at it, it'll give you a peak torque. A peak torque often occurs somewhere towards that mid-range, you know, in and around there. That comes back very, very quickly. And so even when I started at the sports surgery clinic, that's what they were looking at. I'm like, I know this athlete isn't good enough. I know he tests okay in the isokinetic machine, but actually manually how I test it, because I'll test it in its inner and its outer ranges. I'll test it prone. I know this isn't optimal. So we now look, if you have access to an isokinetic machine, look at the full graph output. You'll often find they're down in those inner or outer range angles. And certainly, you know, in what we look at now, we'll look at the peak torque, the mid-range, but also the inner and outer ranges. And from some of the studies, we found that actually, say 4 months post-surgery, the peak torque has come back, but not the inner and outer ranges. And I think that's quite important. We don't know yet if it's predictive of injury. I don't know if we ever will, because there's so many factors that affect that. But for me, I'm always thinking, can my athlete as good as I can? The risk is high of reoccurrence or, you know, whatever. So certainly try and think about the whole rotational arc rather than just peak torque, I think, when it comes to whatever way you're measuring it. The other thing we look at is performance tests. So these are kind of more explosive tests. And that was really based from some of the lower limb literature, not necessarily functional tests. You know, it's another strength parameter, you know, things like peak force and impulse, which means force by time, how they apply force over time. Is that different on some press activities compared to a control group or another limb? And again, interestingly, say 4 and 6 months post-surgery, the biggest deficits are on these performance tests and not on the rotational strength. You know, they're not near as explosive. So say, for example, in our uninjured athletes, they can usually jump about 10 centimetre height on a counter movement press up. And in our injured athletes, average is about 5 or 6 centimetres, you know, at that time frame. So they're certainly not as explosive enough, which doesn't come as a big surprise because it takes time to build these kind of parameters post-surgery. You know, the difficulty with, say, for example, shoulder shape compared to an ACL rehab, the expectations are quite high. Most of these want to be back by 3 or 4 months post-surgery. And they go back to a contact sport. Like, these jumps are mild compared to what they're seeing out in the, you know, out on the pitch. But you have a small time frame to build all of these parameters. You have to be massively structured. You have to have a shoulder that doesn't react post-surgery. Fingers crossed that they haven't touched any other structures in there. And it takes a lot of planning, a lot of work. You can do it. It just has to be on top of your mind, and you got to be adding in your you're building muscle hypertrophy alongside getting the control work, thinking of the rest of the kinetic chain, not just to optimize it, but to build general muscle hypertrophy. Nutrition, you got lots of things to think about for these athletes as you're building them up. So there's some of the things we look at, a kind of performance tests. And the reason being is they're quantifiable. You can modify them, you can change them, they're quantifiable and they're reliable. And then other things like we know from the literature, joint position sense. So we look at joint position sense and an open and closed chain set testing. It's something we're currently looking at publishing at the moment in our non-injured cohort, and then we're going to explore, but we've been collecting that. And then also the lower limb. So we look at some of the lower limb jumps and the counter movement and hoping to correlate that with the upper limb, and is there a relationship there? So that's the battery of tests our athletes go through, but I'm fortunate to work in a facility that has access to that with biomechanics. Again, for anybody who hasn't got that, and that's purely because it's a research thing we're looking at as well, obviously. You don't need all of that equipment. A lot of that, as I said, try and just have a few key things that you know you are reliable in and it's meaningful for you. And I would often say, if it's within a team, have a few key testers that know how to test, that it's reliable. But things like rotational strength, you might have some sort of performance test, whether it's a med ball throw or something like that. If you have a functional test that's meaningful for you, some of there's so many tests there. If you have some of those, and then I think often a screen of the lower body is useful in there as well. And there's different schools of thought on that. I know Margio's in New Zealand as a batch of tests that they use, that they're looking at, and everybody has different opinions. I think it's knowing it's just got to be meaningful to you. Is this the big thing? There's no point just testing for the sake of testing.
And would you say that the return to sport parameters are different from performance parameters that are usually measured, or are they very similar?
Yeah, no, that's a really good question, isn't it? Certainly Claire Adderhern has put some lovely work out there in terms of, there's a big difference between just returning back to your sport and return to performance, and it should be on a continuum. And so they might be back to the sport, but they're not playing at the previous level. There's absolutely, I think, a huge difference. And that actually brings up a really good point. The other thing to think in here is that psychological readiness and some of your subjective parameters, but psychological readiness, and we've hopefully got a really nice paper coming out shortly looking at the psychological readiness of, say, athletes post-shoulder surgery. And it looks like we know from the lower limb literature and from those like Dale Forsyth and Claire Adderhern, and Kate Webster have done some beautiful work looking at actually psychological readiness is likely to be useful in terms of being predictive, or I don't know if the word's predictive, prognostic in return to sport and return to performance. And actually it looks like re-injury in the lower limb. So that's certainly something we're exploring in the upper limb, not just me, but generally in the literature. There's much more stuff coming out there on the psychological readiness. Yeah, and we found, interestingly, so a lot of athletes go back to sports, say, post-shoulder stabilisation, somewhere between 4 and 6 months. And we've looked at our cohort of our athletes, and their psychological readiness drops at 4 months compared to pre-surgery. So they're even lower scores at 4 months. They seem to come back up again at 6 months. But there's certainly, you've got this kind of pre-operative score. It drops at 4 months when a lot of them are actually going back to play and then comes up again. So it's interestingly, probably their most vulnerable time psychologically is when they're often going back to play. But absolutely, I think psychological readiness is another one to kind of consider in there as well, when you're thinking about that, and we're thinking about return to performance as well. And I think they all link. Often if they see themselves doing well on a test, it can help them psychologically. Sometimes they need to just get back and get that first bang on the shoulder to get that boost. But yeah, absolutely. I think it has to be a continuum, and that needs to be incorporated in that time to return to sport. Don't know. Just with the shoulders, and particularly post-shoulder, say the expectations are very high. I think with an ACL, you just often have a longer time frame. They've moved more to waiting the 12 months now, whereas you're often under a lot of pressure to kind of get everything done as good as you can within that time frame.
Very interesting stuff. 2 days ago, we talked to a Belgian researcher, Jente Wagemans, and he talked about ankle injuries, and he also mentioned a psychological readiness, even in that cohort. So there's more and more attention on that part of rehab as well.
Yeah, and the lovely thing is it's so easy to measure. You don't need any measuring tools for that. You use the shoulders, the Cersei score, those are the ones. So it's an easy tool to use and often surprising. You think they're great. And then I remember I had one of the hockey players, and it was going kind of getting him ready for the World Cup, and dislocated. And he was a goalkeeper, so obviously needed to have trusted shoulder. I'm like, you are doing brilliant. Like, this is deadly. The shoulder's testing better than the other side. Amazing. And he's like, I just don't want to fall on this. Like, he could not psychologically, massively really struggled. And you often then have to incorporate, obviously, all your falling techniques, but trying to address that and, discussing all of that, because it's often related to the mechanism of injury. That's how he did it in the beginning. And the brain stores all of this. So no matter how good you look and how good you feel, you've got to absolutely challenge the belief system, previous experiences, the impact of that, all of those things.
That's a good segue to my last question, which is, how does your rehab differ for contact versus non-contact sports?
And let me have a think about how I answer that. How does it differ? Often your contact athletes, there's a huge element in kind of muscle mass and kind of ability to produce force just because of the tackles and things like that. So you'll often be, and a lot of these are quite focused on, they want to be able to bench what they were able to bench before. There's a huge focus around often where they want to be able to do the pull-ups, around building body mass, because that's quite an important part, say, in a rugby player. So often you have a lot of that kind of thing. But not that it not necessarily differs. It doesn't matter what shoulder I see, whether it's a sporting shoulder, a contact athlete, a non-contact athlete. It's still all about getting the small stuff right, getting that local control really good, really optimizing the rotator cuff, getting everything as optimal as you can to be then able to progressively load. No matter if you're missing the small stuff, no matter what you do, you're going to get in trouble when you start to progressively load. They're going to struggle with pull-ups. They're going to struggle with overhead press. They're going to work in a reduced envelope of function in the gym. And that is what will happen if you don't tidy up and get those small bits. It'll always be pinchy. Other little secondary things start to come in. So for me, it's always optimizing that small stuff. Obviously, say with your tennis players and things like that, or your swimmers, a lot of that they often have really good training programs as well, really good resistance training programs and things like that. But you'll often add in some of that thoracic rotation for a tennis player. You're really making sure, or your golfers, or that they have that lovely thoracic rotation. You probably incorporate some of that in with your exercise programs. Versus say your kind of rugby player, which is always in one plane, rather than and for them, they're not overhead tons and tons compared to, say, the tennis players that absolutely can have nothing missing in these corners. With a rugby player, if they have a small deficit, some of them are really grotty shoulders, so they have a really grotty kind of posterior corner, quite a lot of bony changes there. So you'll never be able to access that. So you wouldn't be really pushing into that, because we know there's significant structural change there on occasions on the head of the humerus. So they have like chondral defects and stuff. So you mightn't have to push them, but certainly that would be career devastating for a tennis player, obviously. So that's probably how it differs. Maybe it's like you got to have that, make sure that they're really optimizing that full range, make sure the kinetic chain is involved, you're optimizing the thoracic rotation, versus the contact athletes, where often the focus is get the small stuff really good to then be able to build muscle mass for them to then to be able to, and again, it's position dependent. Some of them need to be quite explosive and quite powerful. And then the other component there is you'll often add a lot of plyometric stuff in, say with your throwing athletes, for example. So you'll be going through a throwing program with your kind of plyometric ball taps, all of that kind of stuff will be incorporated. With your contact athletes, you'll be going through phase 1, 2, 3 of contact. So there'll be grappling lands and falls, and psychologically landing a fall and coming in for a tackle. They're going in on the right foot. So yeah, the return to play continuum probably differs slightly there, but certainly the early stages are probably similar, and then you just maybe have different parameters that you want to chase or that were more meaningful for you or the player.
Okay, I think we've covered a lot of ground, and at the end of the podcast, I'm always asking our guests if there's anything they would like to add, or if they missed a question that would be really crucial for this podcast.
No, Kai, I think you've covered everything there. I hope I'm conscious I've chatted quite a lot there, so I hope I haven't chatted too much.
That's the idea of a podcast. So
no, absolutely not. No, I can't think of anything there. Yeah, no, and thank you so much for having me. It's been a really enjoyable podcast, and always lovely to talk about the shoulder. So, yeah, thank you so much.
Yeah, thank you so much for your time. And at last, where can people find you or reach out to you if they want to get in touch or know more about you?
Yeah, so I'm based at the sports surgery clinic in Dublin. So I have a contact email through there, and I've got some research up on the research gate, so that's where the kind of research papers are. I'm on Twitter. I've recently just got on to, I'm way behind on the social media thing on LinkedIn and starting to update that. So any of those things, it's just under Edel Fanning, most of those. So any questions or anything, they're more than welcome to contact me.
Okay, great. And as already mentioned, we started developing a course together with Edel on the athletic shoulder. It's still quite a lot of work to cover, so probably will come out, in a couple of months.
I'm really excited about that. Yeah. So often I teach in person, but it's lovely to be able to do this now online, and kind of from doing it in person, hopefully being able to perfect it to get a really good 2 days of content in kind of digestible bite-sized chunks is what we're trying to do, isn't it, Kai? And put it together with lots of practical components, lots of videos, and lots of go-to kind of key nuggets to try and help rehab shoulders, the athletic shoulder, but really probably applicable to any shoulder.
I'm sure we'll develop a great product. So no doubt about that.
Fab. No, right. That's really exciting. Thank you.
Okay, Edel, thank you so much for your time,
to the listeners.
For your knowledge, and it was a pleasure to have you. And as always, thanks a lot for everyone out there listening to this episode. And to access the transcript of this episode and additional resources like our infographic, make sure to download our free Physiotutors app and also benefit from more useful physio content. And also, if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts. And also consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll see you or talk to you in another episode. Bye.